it might have happened to you that you have observed a soft mass in a dog and thought it was a lipoma, only to discover with cytology that it was actually a mast cell tumor. Cytology is the tool we are going to discuss that will further help your diagnostic skills and master this fascinating and clinically useful discipline. Hi, my name is Francesco Cian. I'm a vet and board-certified clinical pathologist, and every day I review the cytology samples you send me from your practices and hospitals. Mast cell tumor is one of the most common tumors in dogs, accounting for up to 20% of all skin neoplasms. It most commonly affects adult or old animals, but has been described in dogs of all ages. Some breeds are particularly predisposed, for example, boxers, retrievers, and pugs, but this tumor can also be seen in mixed breed dogs. It most commonly presents as a solitary mass of variable appearance, hence the name, the Great Pretender. A common finding reported by clinicians at times is the fluctuation in size of the mass that may be related to the effects of histamine and other molecules contained within the granules of mast cells and released at the time of the degranulation. But what are the main advantages of cytology over other diagnostic techniques? Cytology is a very cheap, fast, and very effective diagnostic tool as it requires minimal equipment, which I will show you later, and it can be easily performed in-house. Especially for mast cell tumors, it can provide a definitive diagnosis in over 90% of the cases, which is absolutely great. And this is because mast cells tend to easily exfoliate, and because in most cases they have a very typical morphology, appearing as round cells with characteristic intracytoplasmic purple granules, which are also known as metachromatic or magenta. Diagnosis is more difficult in other scenarios, for example when mast cells are poorly granulated, as can occur in some high-grade mast cell tumors. However, don't worry, as we are going to cover these cases as well. What are the different techniques that we can use in cytology to investigate cutaneous and subcutaneous masses? First of all, the choice may depend on several factors, such as the likelihood of exfoliation, the degree of vascularization, and the clinical suspicion. For example, masses that are hard might not exfoliate easily, so fine needle aspiration using a syringe may be preferred. The negative pressure created by the air in the syringe will favor the detachment of cells from the mass, which will go into the cone of the needle. On the other hand, masses that are soft and might not be highly vascularized could benefit from a needle-only technique, which reduces the risk of blood contamination. If you're not sure which technique to use, don't worry. Consider using them both, starting with a needle-only technique. So, what do we need to obtain a good cytology sample? Not much. Some syringes, needles, glass slide, and a pencil. I will show you how to perform the procedure. But before I do, I would like to clarify a few points. Firstly, the choice of syringe. You should use a syringe of between 2 and 5 milliliters to get the right amount of negative pressure. Not too big a 10 to 20 milliliters syringe can damage the cells. Not too small, a 1 milliliter syringe doesn't create enough negative pressure. For needles, a 20 to 23 gauge you might find is the right compromise. However, different needle sizes can also be considered. And as a rule, we can say that the softer the tissue, the smaller the needle and syringe needed. Speaking of slide, I strongly recommend that you choose frosted end slides with rounded corners. The frosted end gives you the opportunity to write the patient details and the location of the lesion on the smear, and these avoid any possible mismatching of specimens. The rounded edges reduce the risk of damaging cells during the smear preparation. By the way, remember to use a pencil to write the information on the slide, as the ink from most pens and markers can dissolve during the staining process. Let's now have a look at the technique in more detail, and for this demonstration we're going to use a phantom. First of all, make sure the slides are clearly labeled and you have all the equipment nearby before starting. Routine skin preparation is the preliminary step before needle puncture through the skin and is similar to that required for vaccination and venipuncture, which means clear the area with the alcohol swab. The mass is then stabilized with one hand, while the needle with syringe attached is introduced into the center of the mass. The plunger is withdrawn and the needle is redirected in several directions several times to obtain a sample that is likely representative of the entire lesion. The needle should remain in the mass during this step. The plunger can then be released before exiting the tissue. At this stage, the needle is disconnected from the syringe. The syringe is filled with air and the needle is replaced. Finally, you can eject the material onto the slide near the frosted end. This sample is then immediately prepared using the traditional squash or compression preparation technique, being sure it will not dry or clot in the meantime. This technique consists of placing a second slide, called a spreader, on top of the first and allowing the material to spread out on the first slide, ideally forming a monolayer of cells. The spreader glass slide can either be parallel or perpendicular to the first smear. And in general, it is important to be careful and don't apply too much pressure, or we risk damaging the cells. You will improve with practice. What do we do after the slide has been made? We stain it. There are several stains on the market that can be used for cytological purposes, and most of these stains are called Romanowsky stains, from the name of the doctor who was one of the first ones to recognize their potential for use as a blood stain. Some of these stains, collectively known as rapid stains, have become very popular in the clinical setting because of their speed, requiring less than 1 minute to complete the process. Of these, DipECVCP is probably the best known. However, because in a small percentage of cases mast cell granules are not visible, identification of mast cells might be difficult. And this is why I use May-Groval-Giemsa Quick Stain, MGG Quick for short. I will now demonstrate how to stain a smear with the MGG Quick Stain, and this is the same procedure as if you have another rapid stain in your practice. So, the slides have now been prepared, and it is important that they are completely dry before we stain them. So you might need to leave them outdoors for a while, such as 10 to 15 minutes. And if there is a lipid component, for example in a subcutaneous mass, the slide might never dry completely. At this point, you can then start the staining procedure. Dip the slide 5 times for 1 second each in solution A. And this is the methanol-based fixative. Then you dip the slide 5 more times, still for 1 second each, in solution B, which is the first stain and is called eosin. Then you continue with solution C, which is the other stain and is called thiazine. At the end of the procedure, you should have a 4th container of distilled water, ideally at pH 7, to rinse the smears. Then leave the smear to dry, and you are ready to examine it under the microscope. In case you want to send the slides to an external laboratory for a second opinion, you can keep at least 1 or 2 of the slides unstained. Then, if needed, you can send both stained and unstained slides to the laboratory. But be sure that these are safely packed in appropriate plastic boxes and are accompanied by submission form with a signalment and all clinical data. What is the step after this slide staining? It's examination under the microscope. And you might have noticed that different microscopes have a slightly different look and setup. I recommend choosing a good quality instrument and having it serviced regularly by a dedicated company. Crucially, it's a very good idea to select dedicated people within the practice who have access to the microscope, and creating a standard operating procedure, SOP, for its use is also very helpful. Remember, the worst enemies of microscopes are dust and immersion oil when it's left on. So, cover your microscope when not in use and clean the immersion oil off the lenses with a good quality lens tissue after you have examined the sample. No need to use detergents, as these are likely to damage the anti-reflective coatings on the lenses. To begin the examination of the smear, turn the microscope on and adjust the light intensity. Be sure that the diaphragm is open and the condenser is up, allowing the microscope light to hit the sample. You can also adjust the eyepieces to make sure that you are in focus. You can now place the slide on the tray and begin the examination at low magnification, which is 4 times and 10 times. This should allow you to assess the cellularity and the general preservation of the specimen. You can adjust the focus using the coarse focus knob. And the next step is select an area of interest and go to a higher magnification, 40 times. Remember to place a long cover slip over the smear which will greatly improve the quality of your view, and everything will look much more in focus. You can also adjust the focus using the fine focus knob. And high magnification, you can start to see the predominant cell type, which in this case are mast cells. But what's the cytological appearance of mast cell tumors? Mast cells generally appear as discrete round cells with large numbers of intracytoplasmic purple granules. As you can see in this picture, these are often very numerous. They can obscure the nuclei and are also present in the background. Other cell types that might accompany mast cells are eosinophils, fibroblasts, and rarely lymphocytes. Eosinophils are easily recognized by their typical segmented nucleus and orange granules. Fibroblasts are mesenchymal cells with a typical spindle elongated appearance. They can also be associated with collagen fibrils, which appear as fibrillar pink structures. Finding these elements in an aspirate can help to identify a mast cell tumor, but at the same time, if they are predominant, there might be confounding factors, and these could be the 5 to 10% of cases that cannot definitively be diagnosed via cytology. Sometimes, mast cell tumors can be more difficult to recognize on cytology because granules may be very few or absent, and cytological features of atypia may be more prominent. These might also be reflected in a different appearance of the mass, which can be more aggressive clinically and being sometimes characterized, for example, by rapid growth and ulceration. A question that often arises is whether we can grade mast cell tumors on cytology, as this could potentially provide very important diagnostic information before any invasive procedures are performed. Recently, a few publications have addressed the concept of cytological grading of cutaneous mast cell tumors in dogs, and in particular, a publication by Camus and colleagues. According to this publication, a cutaneous mast cell tumor is considered being high grade if mast cells are poorly or non-granulated and or these have at least 2 of the following features. And these features are mitotic figures, nuclear pleomorphism, bi-multinucleation, or anisokaryosis, which is the presence of nuclei of different sizes. The algorithm presented in this publication and shown here demonstrates this very effectively. The cytological grading system appears to correlate well with the clinical behavior, as dogs with a cytologically high-grade mast cell tumor were 25 times more likely to die within the 2-year follow-up period than dogs with low-grade mast cell tumor. Knowing the possible grade of the cutaneous mast cell tumor has also the advantage of guiding clinicians in determining which cases require a full clinical staging and establishing the best treatment options. However, both false positive and false negative results can occur, and therefore the histopathological grading systems by Patnaik and Kupel are still considered the gold standard and one of the most important prognostic factors. Let's have a look now at a real case of mast cell tumor that I received recently. The first step is always starting the examination at low magnification 10x, and having a overall looking at the sample, establishing the cellularity, which is really good in this case, and the cell preservation, which is also excellent. When we have identified an area of interest with enough cells, we can move at higher magnification at 40x. Remember to put the cover slip on in order to see things in focus. You adjust the focus, and here we are. As you can see, we have a predominant cell population of mast cells, so these large, round, discrete cells with numerous purple granules that very often completely obscure the nuclei. Together with these mast cells, we have other cell types here, and these are eosinophils with the typical orange granules. In the background, you can also see large numbers of red blood cells, and some degree of blood contamination is quite common in most cytological samples. Let's move around a little bit, and you can see that still the main population of cell types are eosinophils, but most importantly, mast cells. And these mast cells very often are arranged in poorly cohesive groups of variable sizes. In this case, the diagnosis is fairly straightforward and is a diagnosis of a granulated mast cell tumor. If we want to apply the cytological grading system that I mentioned before, as you can see, we have heavy granulation. We do not have significant signs of atypia, so this is more likely going to be a low-grade mast cell tumor. There we have it, a real case of mast cell tumor. Let's have a look now at another case of mast cell tumor. This is a fine needle aspirate of a large shoulder mass that rapidly grown in an adult boxer dog. We always start at examining the slide at low magnification in order to appreciate the cellularity and the preservation. We go at 4x, and we can already see that this sample has a very high cellularity and likely a good preservation, so there are good chances that the sample will be diagnostic. We move at a slightly higher magnification, ideally 10-20x, and this will allow us to appreciate the background, which is clear with a moderate number of red blood cells. And as you can see, we have a population of fairly monomorphic, large, round, discrete cells. And already at this magnification, you can see that some of these cells contain some granules. We move at a higher magnification, 40x, and you can see that these cells have a moderate amount of lightly basophilic cytoplasm with defined borders, and some cells contain also variable numbers of intracytoplasmic purple granules, also called magenta or metachromatic. Other cells, though, of the same cell type, they don't contain any of these granules. Overall, these findings are supportive of aspiration from a mast cell tumor, but as you can see, it is significantly different from what we have experienced before. Different because the amount of granules is definitively lower, and some cells don't contain any, and also because the cells overall show much more marked features of atypia. And of these features of atypia, you can appreciate, for example, the presence of some degree of anisokaryosis, so variation in nuclear size, And just to give you a couple of examples, you can see here that this cell has a nucleus which is likely twice compared with other mast cells of the same cell population. We also have the presence of mitotic figures, and here you have an example of a mitosis. And here and there we can also see that we have some binucleated cells. If you remember what we said before, if we have a reduced granulation, and in this case we also have several features of atypia, including mitosis, binucleation, and anisokaryosis, we can consider this being a high-grade muscle tumor. And in this specific case, histopathology confirmed these cytological suspicions. I hope that these two cases help you to appreciate how muscle tumors look like and how heterogeneous and how variable their appearance can be.